Good morning, everybody. Today we are going to talk about anterocruciate ligament injury and its rehabilitation. So, anterocruciate ligament arises from the tibial plateau just anterior and medial to the tibial eminence. It courses superiorly, laterally, posteriorly to insert on the posterior margin of the middle wall of lateral femoral condyle. ACL is composed of two bundles, anteromedial and the posterolateral bundle. Anteromedial bundle is taught in the flexion and posterolateral is taught in the extension. So this is the basic anatomy of the knee joint in which yellow color ligament is denoted, that is the ACL ligament, and these are the other structures surrounding the ACL. ACL is primary restraint to the anterior translation of the tibia and serves to control the hyperextension of the knee. 85% of restraint force is provided by ACL to anterior translation. Remaining 15% is provided by the collateral, MCL and the LCL, capsule and the IT band. It also serves as a secondary restraint to the valgus and the varus stress. ACL is one of the most strongest ligament and most commonly injured ligament of the knee joint. ACL get injured in the contact and non-contact sports. Mechanism of injury: valgus force applied to flexed and laterally rotated knee with foot planted, hyperextension injury, hyperflexion injury, and direct valgus forces. These are the most commonest mechanism seen in the ACL injury. So in the diagram, first we can see hyperextension, second valgus, third internal rotation, and the fourth is the deep flexion, that is squat. So 90% of the ACL injuries are seen in the individuals with 15 to 45 years of age, usually engaged in the sports activities that places high demands on the knee joint. Sports like football, skiing, basketball, soccer, cricket. About 75% of the ACL ruptures or the tears occur in the mid substance, 20% occurs in the femoral attachment, and 5% occurs in the tibial attachment. This is the most important aspect of the ACL injury we see, or common is the cases we see, that is the mid substance tear. Women's tends to have higher incidence than the men because of wider pelvis, increased laxity, increased genu-valgum, altered muscle pattern, which may be due to the hormonal imbalances and the changes. So we'll see why. So first is the increased Q angle that may directly impact on the knee joint, on the ACL. Less power, poor landing mechanics in the sports, it plays a vital role for this injury. Slow reaction time sometimes also lead to sudden jerk and ACL injury. Anatomical differences in the few people will lead to this type of a problem, and hormonal changes basically in the females will lead to ACL injury. So clinically, patients may report an audible pop or crack sound at the time of injury, pain, immediate swelling within a 2 to 6 hours after the injury, inability to continue the activity, buckling or giving away of the knee on attempt to walking or a weight bearing. This will be seen after the 2 to 3 weeks. Restricted movement, it is a typical complaint of the patient, and tenderness on the knee joint. So ACL injury may occur alone or associated with other injuries like meniscal injury, ACL with avulsion injury, ACL with tibial plateau fracture. Radiologically, ACL tears are seen better on the MRI because this is a soft tissue structure, and I think it will be seen better on the MRI, and this is what studies also shows. X-ray includes AP view, lateral view, and the patellofemoral view. Mostly X-rays are used to exclude fractures along with the ACL. Measurement of a notch width, evaluating joint space, patellar tendon height, and any other structure are seen. Clinical diagnosis is made by increased anterior translation of the tibia, documented by the Latchman test, pivot shifting test, and anterior downward test. After getting diagnosed with the investigation finding, physical findings plays a vital role for confirmation. So in that we can say a Latchman test, pivot shifting test, and the anterior downward test. So this is a normal MRI on the left side, and on the right side you can see the torn ACL. A torn ACL does not heal. An ACL deficit knee leads to rotatory instability in the patients and result in the functional disability. Treatment of the ACL deficit knee depends on the many factors, including age, activity level, occupation, sports engaged in, and amount of laxity and the arthritic changes. So non-operative management indicated in more sedentary individuals with no associated injury and the damage to the other joint structure. Those who are willing to modify the lifestyle can get better result with the conservative management. Treatment aims patients' education, bracing exercises, and the functional training. So that will resolve the inflammation, restoring the range of motion, regaining the muscle control and the protection. That can be done with the cold and compression, isometric exercises for quadriceps and hamstring, assisted devices for the ambulation like knee brace, exercises to strengthen the muscles, especially hamstring and the gastrocnemius, that pulls the tibia posteriorly, open chain, uh, open kinetic chain and closed kinetic chain exercises to improve the strength and endurance of the joint as well as muscles. Surgeries for ACL involves reconstruction with the autograft or allograft, direct repair, repair with the augmentation. So this approach mostly if patient fails in the conservative management. Basically, there are two post-operative rehabilitation. First is traditional rehabilitation protocol, and second is accelerated rehabilitation protocol. So in the traditional, it starts late, requires long duration, so progression is less, or you can say delayed. That in the accelerated rehab protocol, start on the same post-operative day, less time duration, progression are faster, good recovery, and the early joining to the sports activities. So treatment phase one will do reduce the pain and the swelling, regaining full passive knee extension, restore patellar mobility, re-establish quadriceps and patellar mobility, restore the independent ambulation. So this will be the focus in the first week or first phase. Then now the second phase, maintain the full passive knee extension, increase knee flexion, restore muscle strength and endurance, achieve weight bearing, get initiation and the functional exercise. This will be the goals or therapists will focus on these points during the phase two. The phase three, normal and full range of motion, neuromuscular control, improving strength and endurance, improving proprioception. The phase four, strengthening must be continued, neuromuscular control drills must be there, activity specific drills, and beginning of the sports. So this is how we are going to manage the ACL conservative patient as well as the operative patient in by using these two protocols. Thank you.